Thanks everyone for coming on a Saturday morning. Sorry, this photo was taken 12 years ago. So if I had known, I would have given them a recent photo. Next time I'll keep that in mind. Okay, so I'm Imran. I'm an endocrinologist and physician. So I just wanted to give you guys an update on the changing paradigm in terms of obesity, because a lot has happened since the introduction of Ozempic into the pharmaceutical market. There has been a lot of drugs in the background, which are in development, and I think some of them we would be seeing this year. I am actively involved in 3 clinical trials as a principal investigator. So I'm starting 2 clinical trials this year on obesity and diabetes and prevention of cardiovascular disease amongst those population. One of the trial in which we are looking at the combination of semaglutide and carnitine, which is a amylin analog, in which we are looking at the weight reduction in both patients with diabetes and obesity, and their effects in prevention of cardiovascular disease. From next year, we are going to trial the oral semaglutide in Australian population. So that would be hopefully starting from January or February. And we are also trying a triple agonist, which is going to start off in October, November, in which we are going to combine the GLP-1, GIP-1, and a glucagon analog, and looking at the efficacy of these drugs in diabetes and the obesity field. So if you have any patients, you're more than welcome to refer them for trials. And we have a trial team at Hollywood, and we will give them a lot of information, and so that if they want to enroll in these trials. So we'll just start the presentation. Tirzepatide. So this is the new kid in the market. So tirzepatide is going to be here soon, probably in September, October. This drug is basically a dual agonist. It's a GIP-1 and a GLP-1 analog. So this data was recently released in the ESA conference a couple of months ago. As we know that obesity is a complex and metabolic issue. The prevalence is going high by 2035, 24% increase in obesity. In Australia, it's going really, fast at the moment. In adults and in middle-aged people, 1 in 4 people is obese. Every 9 minutes, we have a new diabetic diagnosed. 500,000 Australians, they don't know that they have diabetes. So tirzepatide is a once weekly GIP-1 and a GLP-1 receptor agonist, which has been approved by FDA, and it has demonstrated a good glycemic control and weight reduction in the SURPASS trials in people with type 2 diabetes and the SURMOUNT trials. So these were 2 trials in which they separately tested it for HbA1c reduction and weight reduction. So we will be talking about the SURMOUNT trial, in which we will look at the safety of the tirzepatide and also the efficacy of this drug. Just to give you a bit of a idea of what it looks like. I mean, it doesn't make sense, but what it is that it's GLP-1 analog. Most of us are already very familiar with GLP-1. It's a hormone which is produced by our own body. They just change one of the amino acid sequence so that it can last longer in the system and the half-life is increased. So they have done the same thing with the GIP analog. You can call it a glucose-dependent insulinotropic peptide, or you can just call it gastric inhibitory peptide. So the physiological function of this peptide is that it reduces the acid secretions to prevent the intestinal mucosa from the acid damage when we are not eating. But it also produces insulin, and because it's an incretin, in the hippocampus and in the brain. It has some satiety effects as well. So this was the study design. The primary points were to demonstrate that the two different doses of tirzepatide, 10 and 15 milligram, and we see how much the change in the body weight was achieved, and the definition of the response was more than 5% of body weight loss during 16 weeks of treatment. Then we have key secondary points, looking at how many people are achieving 10, 15, or 20% weight reduction, HbA1c reduction, and HbA1c targets such as less than 7, 6.5, and 5.7. And then when these things happen, then as a complementary byproduct, you can see the change in the fasting glucose and the waist circumference as well. Additional secondary points was obviously looking at the absolute body weight change, fasting insulin, and physical functioning, and also looking at the lifestyle scores and psychological scores, looking at the lipid profile. So obviously, obesity has a very close connection with mental health, positive self-esteem. So when these changes happen, this positive self-esteem improves, psychological health improves, physical health improves. We have seen that often these trials, they do the 3D body composition scans, and there is no lean muscle loss with the use of these drugs. Mostly it's the fat loss. Often people who are not physically active, they may lose lean muscle because obviously these drugs are not letting you eat. So that's a direct effect of not eating or an inactivity rather than these drugs causing lean muscle mass loss. So if the people are a bit active in daily life, as per the WHO recommendation, if they're doing 150 minutes of exercise per week, they would not lose any lean muscle mass. So the way they double-blinded them were that at the screening, so you get 2.5 milligram, and every 4 weeks you escalate it by 2.5 milligram. And then around at week 20, your dose is 12.5 milligram. And then obviously, depending on the side effects, they kept going up to the full dose of 15 milligram. Key inclusion criteria was pretty straightforward. Adults age above 18, BMI 27 and above, or diagnosed with type 2 diabetes. Patients who are not really well controlled with their management of type 2 diabetes, except for DPP-4s and GLP-1s. And exclusion criteria was that patients who are currently on these medications or type 1 diabetics, or any prior or planned surgical treatment for obesity, because we know that after the gastric sleeves and gastric bypass, the physiology of the incretin and the ghrelin, it changes a bit. So that can add some confounding factors in interpretation of the data. So that's why they were excluded. So this is just it's a busy slide, but just letting they're just letting us know that everything was harmonized and there was no differences between the placebo and the treatment arm. So when we look at the percentage weight change, so we can see that there was 12.8% weight change for the 10 milligram dose at 72 weeks versus 14.7 for 15 milligram. And we can see that placebo can mean anything. They can still be on any other weight loss drugs such as Duromine or Contrave, or they might be just having some saline. So there was a significant decrease in the weight, as we can see from the start to the end of the trial. And obviously, the higher the dose, the more the weight loss. Patients who achieved weight reduction targets at 72 weeks. So we can see that, interestingly, the most, I think, successful part of their trial was, if you look at these two slides, more than 5%, that's fine. We have seen that with semaglutide as well. You can achieve that with Duromine and Contrave. But I think for me, the most exciting part was this: people losing more than 10 and 15% of their body weight. So you can see almost 65% people lost more than 10%. and almost 50% lost more than 15%. So which means 1 in 2 people will lose more than 15% of their body weight. For me, that's a very positive result, because we know that weight loss has been a very challenging management aspect of our clinical practice, and the drugs that can achieve this without any significant side effects. Because if you look at their, which I will talk about, if we look at their side effects profile, it's almost similar to semaglutide, Trulicity, and exenatide that we have used in the past. And this is the group that has lost more than 20%. So you see that 30% people have lost more than 20% of their body weight at the end of the trial. And yeah, so almost this is the same, I think, interpretation. And we have another group, which is 25%, which is obviously, we would not expect that number to be quite big. So almost 15% people lost more than 25% of their body weight during this trial. And you can see that this is another way of saying what we have said in the previous slides. You can see that the percent weight change and in terms of the proportion of the body weight. So you see that the placebo is sort of not moving that much as compared to these two drugs. So you can see that 25% weight change for this one was in 15% people, and it keeps on going up. So it's just, I think, another way of plotting the data that we have just seen in the previous slides. The changes in weight circumference, we can see that for the 15 and 10 milligram, there was 13 and 10% change in the waist circumference as compared to the placebo. And obviously, this is not a surprise if you lose that much of weight. HbA1c targets were achieved better because we know weight loss can put the diabetes in remission, and it improves your pancreatic function, insulin sensitivity, and your lipid profile. So you can see up to 2% of decrease in the HbA1c. And we can see that they started at HbA1c of almost 8%, and they finished almost in remission of their diabetes, which means if they can maintain that weight, the diabetes will stay in remission. And again, this is again a very strong, I think, slide, because you see patients who achieved HbA1c target at 72 weeks. So you see that with the less than 7%, so almost 86-87% people have achieved their HbA1 targets. So, and that goes with the weight loss, improved pancreatic function. Less than 6.5, you have 80%, and 1 in 2 people you are putting in remission. So less than 5.5, 5.7%, which is almost remission of diabetes. So if you give it to 2 people, 1 will go in remission. Fasting blood sugars. Again, I'm just gonna skip through this one because when they're going in remission, obviously their blood sugars will go down. Changes in lipids, we can see that the bigger dose has more change in terms of triglycerides, non-HDL cholesterol. HDL has gone up, which is a positive sign. Total cholesterol goes down, and your chylomicrons and VLDL-C, which are, I think, if we look at the data, they are more accurate in actually predicting your cardiovascular risk, such as apolipoprotein B and apolipoprotein A. So they also go down, and they go hand in hand with the profile of your lipids. Decrease in systolic pressure. We know that when you lose weight and obesity is one of the major causes of burden on the kidneys and high blood pressure. So with weight loss, you get these extra benefits. A reduction in the systolic blood pressure up to 7 and 6 millimeter of mercury, and with both the 15 and 10 milligram doses. Adverse effects, we can see that they're almost similar to the usual GLP-1s. Interestingly, diarrhea was more in the 15 milligram group. Nausea was common, vomiting, blood calcitonin and elevated pancreatic enzymes. I will touch these two because there are receptors of GLP-1 and GIP-1 on your thyroid and also obviously on the pancreas. So if these patients are on these drugs, you might see a bit of a rise in their lipase, which is normal. So their lipase may go up to 90, 100, and that is fine. We don't need to do anything about that. That is because the drug is acting on the pancreas, and lipase is one of the secretion of the pancreas, as we all know. So if it goes slightly up, we should just ignore that, unless it is, too high or patient is coming with symptoms of pancreatitis. Also, the calcitonin, obviously, we have receptors on the thyroid. It doesn't mean that the patient is developing a medullary thyroid cancer because of that. So there are weak receptors there. And there are some studies in the rodents and the mice that, it increases those receptors in those species, but not in humans. So far, there is no data to suggest or confirm that these drugs cause medullary thyroid cancer. So this is just, I think, combination of all the side effects. And we can see that cholelithiasis, cholecystitis, and cholecystectomy. I don't think this is drug specific. I think it's more of a weight loss thing. When we lose weight, there is a lot of cholesterol deposition in the gallbladder, and that causes gallstones. So if you look at the data, all these people would have cholesterol gallstones. So this is like with any weight loss, you can have gallstones. So I don't think these are drug specific. Diabetic retinopathy complications, not really significant. Hepatic events, not really significant. Malignancies, those malignancies which were reported were not directly related. Then you had 2%, one patient had an episode of pancreatitis. Cardiac disorders, they were not really related. And you have all the, so there has been a bit of a literature about the suicidal ideation. And we have seen that in some of the patients who have been using Ozempic and semaglutide. So that was an area of particular interest in this trial to see whether these patients are prone towards or maybe, getting more sort of depression and suicidal ideation. Because I've seen some of my patients who I've prescribed Ozempic, they have become depressed. And I always ask them if it is affecting their daily life, then I stop the drug. So that was the area of particular interest in this trial, but as the data says, there was nothing significant statistically to be reported. So in a conclusion, we see that up to 82.8% of people achieved more than 5% weight loss, and more than 30% achieved more than 20% weight loss, and up to 15.15% achieved exploratory endpoint of 25% weight loss. Finding of this obviously trial will add, more options in the therapeutic, guidelines to address this problem of obesity and type 2 diabetes. And the most frequent side effects were the gastrointestinal side effects, which we know are common. So I'm just going to skip this. These are my supplementary slides. And I'll just show you the comparison of tirzepatide in the SURPASS trial when they compared it with the insulin, long-acting insulin. So that was another trial in which they looked at people who were already on a long-acting insulin in type 2 diabetes, and they put them on the tirzepatide. So I'll just give you the conclusion. So when people who are already on basal insulin for type 2 diabetes, so when we add tirzepatide to those patients, or we compare it side to side, there is more reduction in the HbA1c as compared to the patients who are just on the basal insulin. And you can see that up to 80% and 70% people had reduction of HbA1c of less than 7 and 6.5 respectively, as compared to the basal insulin, which was 37 and 22%. The more interesting point was that when patients were on these drugs, so the daily use of insulin was substantially lower in patients receiving tirzepatide. So you can see that the dose of glargine was only 13 units as compared to 42 units. And patients with obviously treatment group lost weight, and the rate of hypoglycemia was low for tirzepatide. And obviously, we know insulin is, it doesn't cause weight loss. So obviously there was weight gain. So this is, when I see these patients in my rooms, or in my clinic, my aim is to get them off insulin in long term. I often see patients who come with basal insulin and on Novomix and all this stuff. So my aim is that when I see them again in 6 months, 9 months, 1 year time, my aim is to get them off insulin eventually. Insulin for me is a terrible drug. It treats your number, but it doesn't, gives you, I think, morbidity or mortality benefit, because, I think it adds more problem in future rather than giving you, it gives you like a short-term solution. That's how I interpret it. It will make your HbA1c better, but next time you will need more insulin and you go into this vicious cycle, you will gain more weight, insulin resistance. So when I see these patients with a good diet plan, adding these medications, giving them a script of SGLT2 inhibitor with this, and one of them can be a private script to fulfill the PBS guidelines. So often I give them SGLT2 on a private script, which is a bit cheaper than these drugs. So combination of different drugs and reducing the dose of insulin. And that also, I think, motivates the patients when they start seeing the effect. So most of them will work towards a healthier lifestyle as well. In fact, I saw a patient on Friday. So when I started seeing him 9 or 10 months ago, he was on 62 units of Ryzodec BD. And when I saw him on Friday, he was not on any insulin. So I think these things can work. And that is the excited part for me, that we can get rid of insulin, especially in the type 2 population. Just touching base on this drug, I think this is still in the pipeline. So this is a non-peptide GLP-1 agonist, which is called orforglipron, and it is a oral drug. It's a daily drug, and it has been in the phase 2 study. So I think in the next couple of years, this drug is going to hit the market as well. And this data was also presented. So it's still in the development in the treatment of obesity and type 2 diabetes. It's a partial agonist. What it does actually is, it's just the difference in the mechanism of action as compared to the other peptides. Half-life is not as long as the other drugs. That's why it's a daily intake of the drug. There is no restriction of food or anything or other medications. And the objective of the phase 2 trial was to look at the efficacy and safety of this drug as compared to the placebo. Obviously, the primary endpoint was to look at the body weight reduction at 26 weeks, and all the secondary complementary endpoints come with it. The inclusion criteria was BMI more than 30, HbA1c less than 6.5, and stable body weight for 3 months. Exclusion criteria was poor renal function with a GFR of less than 30. And we can see that there is a dose escalation, and they went up to 45 milligram depending on the side effects and the tolerability of the drug. So this is a very good result, because you see that 14.7% weight loss, and this is only 36 weeks. So the previous study that I showed you was at 72 weeks. So 14.7% weight loss in half of the time of the tirzepatide. And the side effect profile is almost the same. And obviously, as the dose goes up, you can see differences in the weight loss. So the more is the dose, the more is the weight loss. When you look at in terms of numbers, so that is 15 kilos in 36 weeks. And 75% of people achieved a target of more than 10% with 36 milligram dose. So this dose was the most tolerated dose. Obviously, when you go to 45 milligram, there were more side effects, but this was the most tolerated dose. So that's why they picked this one. And with this dose, 75% of people lost more than 10%. Safety information was almost the same. It actually improves your liver function. So you can see that improved in the liver enzymes. No confirmed cases of pancreatitis or any gallbladder problems. Increased pulse rate were observed, which is very consistent with all the GLP-1s and the GIP-1s, but we don't know the mechanism yet. I think it's more a hypothesis is because of weight loss and blood pressure. So the pulse rate slightly goes up, but we don't know. So the summary is that obviously this is a new drug which is going to be, in the market soon. 36 weeks is a very impressive time for 14.7% weight loss, and it's going to go into the phase 3 in a very open, sort of population, because phase 2 is very restricted, and we'll see in a control environment, but more real life, effects if they can reproduce these data in the phase 3 as well. So that would be the end of my slides. I'm open to questions. And
patients who achieved a remission of their diabetes, you then stop the drug, or do you just continue?
So that's the question. I put it back to the patient, and I asked them that, look, whatever we have achieved is obviously with the hard work of your lifestyle plus the medication. So now it's up to you if you want to have a drug holiday and see if you can maintain it. But again, the set point theory kicks in here, because your hypothalamus will push you back to that weight. But now the thing is that how much you can fight it back. So we have seen that for your body weight, let's say someone has lost a weight of 100, from 100 they have come down to 85. So we have seen in the studies that to fight the set point theory, you have to eat 500 less calories for your body weight, and you will maintain that weight. So if someone can be that strict that they have this discipline in life, that for example, for 85 kilo person, the calories are 2200, and they're happy to eat 1700 calories, and they can stick to that. So yeah.
I'm just interested with the mean lean muscle mass was not lost. Is that better than with the other drugs in that category?
It's comparable. There is no.
If you lost 15% of their body weight by diet or post-bariatric surgery, we'd expect them, even with exercise, to have lost lean muscle mass. So is there something about the drug that stops that happening?
Because the drug is basically, it causes fatty acid oxidation. These drugs, specifically tirzepatide, it causes fatty acid oxidation rather than working on the glycogen.
So if you've got someone with sarcopenia, just with age or something, you might go that one more than.
I mean, if someone has sarcopenia, I don't think this would be a very good choice for them. For two reasons. One is if they have sarcopenia, the whole idea of putting diabetes in remission would not apply to them. Does it make sense?
Sarcopenia is, I suppose, part of aging, but then there's people who get earlier sarcopenia.
No, I understand that. What I'm saying is that if someone has sarcopenia, I don't expect their BMI to be very high.
Okay.
Yep.
Not necessarily. Well, if it's part of aging, no. Yeah.
Yes, but I mean,
BMI was just dependent still fine.
So let's define the age then. Like if it's 80 years old.
Maybe 65. Yeah.
Yeah, I usually don't use them. I usually don't use these drugs in patients who are sort of, lowish BMI, because I see that there is no sort of benefit there. Because, for me, it's more about reducing insulin resistance, reducing weight, putting the diabetes back into remission.
I'm thinking of a patient I've got who's got inclusion body myositis in their late 60s.
That's a very special sort of a scenario, right?
Yeah.
Yes.
And they're on Ozempic, fully controlled diabetes, and I'm just thinking, is one of these drugs better? Yeah.
So far, the best data you have is for Ozempic.
Okay.
All of them have. And I mean, you can try these patients on, pancreatic sparing agents such as SGLT2s.
I've got a question over there. The exclusion criteria, you did mention about the renal function of less than 10 kg/30. So apart from the renal function, patient with a chronic pancreatitis, is an exclusion. And I've got one of the patients, she had acute pancreatitis twice, but doesn't go into the chronic phase at the end. But she had a lipase level goes up every now and then. So if that type of patient, is that suitable or is that?
So what was the cause of acute pancreatitis?
course is unknown, she is under the specialist, one of the
Yes.
professors of Hollywood. Of course,
So I have few patients who have had pancreatitis in the past and I've used these drugs on them, but the cause of their pancreatitis was more of a mechanical one, such as gallstone or, a spasm of their duct. So if there is a more such like a mechanical or anatomical cause, then I use it. For people who have idiopathic or for people who have had drug-related pancreatitis, then I don't use it. Yeah. Sorry. Yep.
Expecting this particular to be
I think it's minimum of a couple of years because it's going to go through the phase 3 trial.
How about the version of that?
It's coming in September, but it won't be PBS. I think. Yeah. Sorry. Same question. Yes.
Dr. Badshah, I had a few doctors send my patients back to me for insulin for type 1, and they've asked me to start Saxenda.
Yes.
What do you think about that?
I've used it. I used SGLT2 and the GLP-1s both on patients with type 1 diabetes. But I select my patients very carefully. The reason is that if I see a sensible type 1 who has a good grip on the management of the diabetes, but sometimes we have to be aware that it's not the person who is doing wrong, it's the nature of the disease that's failing the person. So that sort of population, I tried that and I have seen good results in reducing their dose of insulin and stabilizing their diabetes. So it's not like a blanket rule, but I select my patients carefully and I see whoever is more sensible to deal and checking their ketones and making sure that they don't go into decay with these drugs. So I definitely use it. So, but I tell them it's an off-label use. I've been using Ozempic.
Yeah.
Yes, I think Saxenda, it's gone now. Yeah. And you trust me in let's say if we have another talk like this in 12 months time, I am very sure that Ozempic, I will be saying this about Ozempic as well. Yeah.
There was this question from the Zoom world, which was the association with thyroid cancer.
Yes.
So
So the question is, one of the participants from Zoom is that what is the association with thyroid cancer? So we have these receptors on the thyroid, the GLP-1 and the GIP-1 receptors, and it can produce some calcitonin. So far, the data has not yet proven any association or as a cause effect between this drug and thyroid cancer. The trial that happened in the past, I think it was the exenatide trial, after which they started giving this black box warning of thyroid cancer, was there were 2 people who had medullary thyroid cancer, but their RET oncogene was positive. When they looked at the genetics of those patients. So those patients were going to get cancer anyways. However, it has happened in the trials that they have to put a warning, but so far the data has never shown any cause and effect association between the two. All right, thank you very much.
thank you very much. So we'll move on to our next speaker, which is Dr. Duck.